My name is Mark Lockhart. I'm Professor of Radiology and Chief of the Body Imaging Section at the University of Alabama at Birmingham. I'm going to be talking on biliary and pancreatic ultrasound. In this lecture, we are going to cover the indications for biliary and pancreatic ultrasound, the technique for ultrasound in these areas. We're going to cover most of our time with normal structures, benign abnormalities, and biliary tumors. The clinical indications for right upper quadrant ultrasound and evaluation of the biliary system and pancreas is most commonly biliary colic, right upper quadrant pain and fever. This is when the clinician is concerned about cholecystitis or cholangitis. In these cases, there may be a waxing and waning of the pain over 1 to 3 hours. Another indication is when liver enzymes or liver function tests are abnormal. Also, if a patient presents with jaundice and there's concern for biliary obstruction, these patients will often be referred to ultrasound. For the normal biliary anatomy, the intrahepatic ducts join together to form the portal radicals, which join together to form a common hepatic duct at the liver hilum. A few centimeters beyond that, the gallbladder and its cystic duct join to form the common bile duct, and then the common bile duct joins the pancreatic duct at the ampulla vater to join into the duodenum. There's a variety of information in the literature about normal size criteria. Generally, if the gallbladder is less than 5 centimeters diameter, this is considered normal. Also, the gallbladder wall should be less than 3 millimeters thick. For common duct, there is some variety in the literature, but traditionally we've considered that if the common duct is less than 5 millimeters in a person less than 50 years old, that is normal. And we'll add 1 millimeter for each decade above 50. So 6 millimeters at 60, 7 at 70, and so on. Also, if the patient's had cholecystectomy, that may enlarge the common duct an extra millimeter beyond the expectation. It should not be considered normal if the common duct is more than 10 millimeters diameter. And then there's been some other recent articles that suggest possibly a 7 millimeter threshold for normal, regardless of age, could be considered. So here's an example of a normal ultrasound of the gallbladder. The wall should be thin, you've got the normal echogenic surrounding fat, and the bile within is anechoic without layering debris or stones. For the common duct, it may be difficult to see the entirety of the length, but we can usually find a fairly good segment since it's pretty straight. You want to look in the region of the portal vein, often slightly superficial to that area. It'll have paper-thin walls and should be anechoic centrally due to the presence of bile. Now on a CT, we can also see it as a circle of hypointensity or hypodensity, again containing the bile within the pancreatic head. This is an example of the cystic duct, and you can see this circular or spiral type of appearance. This is due to the spiral valves of Heister, which are commonly seen in this region. Switching over to pathologies, we're going to focus on the benign pathologies first. These are gallstones, ductal stones, gallbladder polyp, acute cholecystitis, adenomyomatosis, and pancreatitis. We'll also consider rarer entities such as a choledocolithiasis cyst, Caroli's disease, gallstone ileus, and Mirizzi Syndrome. For malignant diseases, we're going to consider Cholangiocarcinoma and Gallbladder Carcinoma, biliary metastasis, Ampullary tumor, cystic lesions in the hepatic portions of the bile duct such as biliary cystadenoma or cystadencarcinoma, Pancreatic Adenocarcinoma, and then IPMN is another lesion that can occur in this region. As our first case, we're going to start nice and easy. So we have a gallbladder with paper-thin walls. Within it, there are multiple echogenic shadowing foci, which are mobile, and I think most of us would be fairly comfortable in easily coming to the diagnosis of gallstones in this patient. Now, it may be a little bit harder in a case like this where you see a layering portion of echogenic debris, and you're not quite sure if this is shadowing from that layer or not. Typically, we would consider this would be gallbladder sludge versus sand-like gallstones. In this case, even if it's predominantly sludge, there's probably a little bit of stone disease mixed in these patients. In this case, we have what's called a wall echo complex, or Wes sign, and you can see the echogenic near-field wall here, and then there is a dark line between them, which is the bile in the gallbladder lumen, and then this second echogenic line, or the shadow of the Wes, is the front edge of the large stone with complete shadowing behind. This is consistent with a large gallstone filling the lumen of the gallbladder. In general, gallstones are round, they're mobile, they're echogenic, and they're shadowing. Up to 80% are cholesterol stones, and then this is associated with many clinical situations such as pregnancy, oral contraceptives, hormone replacement therapy, obesity or TPN, Crohn's disease patients can have these, and then also with rapid weight loss. Here's an example of layering very fine debris, which is not really a dense layer and there's no shadowing. So this is one that we would feel pretty comfortable calling gallbladder sludge. Now it's just a very thin, fine sediment. They may have the same risk factors as stones, but this can actually just go away and resolve on its own. There should not be any shadowing, even though it may be echogenic. And then one consideration is that these patients, even if they only have gallbladder sludge, are at increased risk for developing cholecystitis or pancreatitis in the near future. Our next case is showing again echogenic foci with shadowing in the dependent portion of the gallbladder, and we also have gallbladder sludge layering. As we follow it down, we'll see ductal dilatation coming in an oblique plane, and then we have one focal lesion with shadowing in the common duct, and again a little better view of it highlighted by this circle. So this is a stone within the common duct, otherwise known as Choledocolithiasis, and this patient also had a CT. You can see that with contrast it may be actually pretty hard to see, but when we also had the unenhanced CT image, it becomes much more obvious. Choledocolithiasis can result in biliary dilatation. Often the stone may be echogenic on ultrasound, but commonly these are not seen by CT because they're usually not calcified, and you may only be able to see the point of dilatation. If they're calcified, the unenhanced images can help you to better see them. Our next case. So the difference between this case and the ones that we've seen is notice that all these echogenic calcifications, yes, they have shadowing, but these are not all in the dependent wall. These are on the anterior wall, they're on the posterior wall, they're fairly diffuse. So this is not typical of your standard stone disease. And then on this CT of the same patient, we see that this patient has a classic example of porcelain gallbladder. Punctate linear calcifications. Again, if you're not thinking it through, you might just say that these were gallstones adherent to the wall. It's important to differentiate these, though, because porcelain gallbladder, because it's a chronic inflammatory process, does have a significantly increased risk of malignancy, specifically gallbladder cancer. All right, here's another example. On this image, looking at the gallbladder in a longitudinal plane, we see this sort of rising moon type of appearance, round structure, brightly echogenic with shadowing, so we're saying that there's a gallstone. And now we look at the gallbladder itself and we see diffuse wall thickening. Notice you don't want to measure the wall as it's lying against the liver because there's some tissues that are very loose in that region and can simulate wall thickening. But we do also have this layering sludge in addition to the stone that I've already shown you. So when we have gallstones with wall thickening, we want to check for a sonographic Murphy sign, but with or without it, we're still going to be highly suspicious for acute cholecystitis. Now in this patient, we also have a CT, and you can see a dilated, irregular, thickened gallbladder with adjacent stranding. This is just classic cholecystitis, no matter which imaging modality you use. So again, findings that we'll look for: wall thickening, stranding, discontinuous wall enhancement, hyperemia on color Doppler, obstruction of the cystic duct by a stone, and then rarely there may not be any stones and you may have a situation of acalculous cholecystitis. Now for acalculous cholecystitis, we still use wall thickening greater than 3 millimeters. We'll also look for, we will notice that there's an absence of gallstones or sludge, but they may still have the sonographic Murphy sign. Some authors have suggested that wall striations may help you, and then you can also look for a dilated gallbladder, meaning greater than 5 centimeters short axis diameter. Here's another example where there's no gallbladder sludge, no gallstones, and yet there's diffuse gallbladder wall thickening. This patient was HIV positive, and this one is consistent with HIV Cholangiopathy. In these patients, they may have pain, nausea, fever, jaundice. It has been associated with cryptosporidium. There may be thickening of the biliary walls, and the papilla may also be edematous. Another benign abnormality which we love to show residents because it's fairly classic is this appearance of a comet tail or ring down artifact where echogenic reflectors from the anterior wall are misregistered into the gallbladder lumen, as you see with this circle. And this is classic for adenomyomatosis. The ring down is due to misrepresentation of the depth due to a time delay as the sound wave reflects or rattles around in a cholesterol crystal within the Rokitansky-Aschoff sinuses. This way the sound is actually registered in a deeper location, and it's a very clear, easily identified diagnosis. There can be focal wall thickening, and in those cases it could raise the question for a gallbladder cancer, but again, these should be benign, and we would hope that they would not have to go to surgery. Now, ultrasound can be very hard for this other diagnosis, so I have a nice CT for an example. When you see this gas-filled gallbladder in this, you can use the lung windows of your CT to show not only the gas density but the sloughing of the mucosa and the irregularity. Please note also this extraluminal collection here with fluid and gas. So this is consistent with emphysematous cholecystitis. It's going to be a complete whiteout of the gallbladder since none of the sound waves can pass through the front wall. So you're not going to have any of that bile that would have the West sign for, say, a large gallstone. All you're going to see is one white line completely shadowing behind. And then there may be signs of pneumobilia within the intrahepatic ducts to help you with the diagnosis. Okay, switching again. So this one is a little more focused on the pancreas and still in that non-malignant category that we're discussing. So here we have an example of a pancreas, normal echogenicity. The head is normal size, the neck going all the way to the body. We see a little bit of dilatation of the pancreatic duct here, but nothing very impressive. And again, the pancreatic body, not as big as we might be concerned if they had pancreatitis. Pancreatic tail can be very variable in its thickness, and so that's not very useful to us. We don't see any of the secondary signs such as collection or adjacent peripancreatic fluid. So in the same patient in the same day, they had a CT scan, and I'll just draw your attention to this one image, and you can see that same small amount of biliary dilatation in the pancreatic duct, but notice this peripancreatic stranding. This is a mild case of pancreatitis, which was diagnosed by CT but missed by ultrasound, and I do feel that CT is probably our best study for the evaluation of pancreatitis. Okay, our next image is showing dilatation of the common duct measuring 13 millimeters diameter. So far we know there's biliary dilatation, but we really don't have a reason why. As we look at this second image, I'll draw your attention to the dilated common duct again, here. But look right beside it. There is that sort of rising moon or classic appearance of a stone lying right beside the common duct. So this is a classic example of Mirizzi Syndrome where a stone is wedged in the cystic duct or a cystic duct stump, and there's a common channel with the common duct. Therefore, it will extrinsically obstruct the common duct and create a biliary obstruction. And occasionally there may be a gallbladder fistula to the common hepatic duct in these patients. All right, now we're going to switch over to mass lesions, and we're going to start nice and easy again. This is an example of a classic focal small lesion within the lumen of the gallbladder, slightly protruding inside, and we put color Doppler on. There's not a stalk of flow, there's no hyperemia associated with it. This is your typical appearance of a gallbladder polyp, echogenic, non-mobile, and non-shadowing. These can be adenomatous or hyperplastic. If they're greater than 10 millimeters, these are worrisome, and often these will go to surgery. If they're less than 5 millimeters and you do a follow-up, these actually often resolve and may even be tumefactive sludge that was misrepresented as a polyp. Now, between the 5 and the 10 millimeter, we're in that borderline zone that most people will get a follow-up at 6 months and then maybe even a year later after that, because there's a risk that you may be finding an early gallbladder cancer in these patients. Now, this is a little more worrisome. This is a focal mass in the junction region of the biliary radicals. It's mildly echogenic, and it has biliary obstruction of both sides associated with this. And this one on the video shows how this tumor is protruding into those ducts. And this is a typical central cholangiocarcinoma, otherwise known as a Klatskin tumor. Now, a peripheral cholangiocarcinoma on ultrasound is going to be focal near the periphery, and on CT it will be hypodense on the pre-contrast with a slow progression of the central stroma with potentially a small capsular rim sign, as we see on this one. The key in these is in 36 to 70% you will actually have increased density on the delayed images of the CT. The peripheral, in my experience, are less common than the central or the Klatskin type tumors. Cholangiocarcinomas are more common in elderly patients, and they may present with painless jaundice. Other risk factors include primary sclerosing cholangitis, choledocolithiasis cyst, Caroli's disease, parasites within the biliary tract, or previous thoratrast exposure. Here's another focal mass sort of in that liver hilum, but notice there's not really the associated biliary dilatation that we were seeing with the Klatskin tumor. And then, as you can see right here, there's a little bit of fluid, and this is going to actually turn out to be the gallbladder. Here's an MRI that was subsequently obtained, and we see gallstones within the gallbladder and an eccentric focal mass which is actually invading into the liver parenchyma from the gallbladder. And you can see on these T2 weighted images the edema and the high T2 signal associated with this extrinsic mass coming out of the gallbladder wall. So this is consistent with a gallbladder carcinoma. Here's another example. So we have a focal polyp within the gallbladder, and then a second larger hyperenhancing mass, which is not only protruding into the gallbladder but also extending out. And you can see there are multiple gallstones also associated with this patient. Now, gallbladder carcinoma can be infiltrating in about 2/3 or polypoid in about 1/3. If you use a contrast agent, it'll be bright on the arterial phase and may retain contrast on the portal phase. And then you should look for liver mets or direct invasion, because these can be quite aggressive. They occur in elderly females. They're usually an adenocarcinoma, and then they've been associated with either gallstones, porcelain gallbladder, primary sclerosing cholangitis, or choledocolithiasis cyst. This is our next case, and you can see a focal polypoid lesion on ultrasound in the gallbladder. Again, it's a little dark, but you can still see the eccentric nodular lesion. And there was a little bit of low resistance arterialized flow on the color and spectral Doppler. This patient went on to CT, and we can show clearly that it's not a stone on the unenhanced images. And as we give contrast, we see bright arterial phase enhancement and then early washout. Now, I've withheld a little information from you because this patient had a known melanoma, and this turned out to be a metastasis from melanoma. If you're looking at gallbladder metastases, melanoma is the most common primary source, and if they have multiple hepatic lesions where you're not really sure that they have melanoma, it can look like other types of metastatic disease or even metastatic cholangiocarcinoma. Here's another example of a malignancy. So we start with the ultrasound and we see diffuse severe biliary dilatation, central intrahepatic, and common duct dilatation. And we can put color on to make sure that this is not a vessel that we're seeing. As we go through here, I'll just show you how this biliary dilatation not only is intrahepatic but goes all the way down as far as we can follow it toward the pancreatic head. On the CT, There's diffuse biliary dilatation, and this shows you that it's not only within the common duct, but the pancreatic duct is also dilated as well. And then we can see how this comes down to a focal lesion in the distal common duct, which then sort of blends into this focal soft tissue mass in the ampullary region. So this is an ampullary tumor. You'll often see the double duct dilatation to the level ampullus, such as you might see with a pancreatic adenocarcinoma. CT really has poor sensitivity, and ultrasound's not that great either for finding a small ampullary lesion. Now, it may see the biliary dilatation and the pancreatic duct dilatation that's associated with it, but actually identifying the lesion when it's small can be difficult and may require endoscopy to detect. Here's another example: severe pancreatic duct dilatation coming into this poorly defined hypoechoic mass-like region in the pancreatic head. Put nice little calipers here, really let you see where that is relative to the adjacent structures. And then there's some dysmorphic vascular flow once we see on a color Doppler. This turned out to be a Pancreas Adenocarcinoma. These are often infiltrative, hypodense. You may see, if you do a good pancreas arterial parenchymal phase, it'll be hypodense relative to the surrounding parenchyma. In portal venous phase, we can evaluate for invasion or involvement of the SMV, splenic vein, and portal confluence. We're going to also look for direct invasion into other organs, nodal disease, and then distant metastases. Now, after showing you that last one on ultrasound, I'm going to show you one that looks exactly the same. Here we have a poorly marginated, infiltrative, hypoechoic mass within the pancreatic head. You look at this image and you are thinking cancer. So we look and we see, okay, I've already told you this is not a tumor, but we see pancreatic duct dilatation going into this hypoechoic mass. And look at this all through here. Now, one hint might be these echogenic shadowing structures within the pancreas parenchyma. But again, my sonographer shows me this image of an infiltrative hypoechoic lesion. I am thinking tumor all the way. So this patient had an MRI, and I'll draw your attention to several different points. Here's your cystic changes. There's little side branch dilatation. Pancreatic head is irregular, and we've got a focal high intensity signal lesion right here, which is going to be consistent with a stone. And then as we see the pancreatic duct dilatation, I don't know how well you can see it, but there's small side branch areas of dilatation throughout this pancreatic body and tail. So this is actually chronic pancreatitis, but it was a very mass-like appearance of it. There was the irregular ductal dilatation, focal hypoechoic, not anechoic, collection, which looked all the world like a tumor. If you're able to see the side branch dilatation by CT or MRI, you might suggest the diagnosis. And then again, if you see those echogenic shadowing stones within the pancreatic duct, you might think, well, maybe this person's had recurrent pancreatitis, therefore the calcifications, and then you might be able to sort of think about something other than tumor in this case. Well, that's sort of a whirlwind tour through the biliary system and pancreatic abnormalities by ultrasound with a little bit of correlation. I hope to point out that for many biliary and pancreatic abnormalities, ultrasound can make the diagnosis, and then also ultrasound can help you differentiate benign from malignant disease. Thank you for your attention.